انا هتكلم دلوقتي على extended depth of focus IOLs filling the gap بحيث ان احنا نفهم بس الايرا اللي احنا ماشيين فيها حاليا من ناحيه البريميوم IOLs. اولا بادئ زي بدء I don't have any financial interest علشان ممكن اقول اسامي شركات او اسامي برودكتس وسط البرزنتيشنز مش معناها ان انا ما فيش شركه يعني في حد يكلمني يديني فلوس ولا حاجه، مع اني ما عنديش مانع يعني لو حد عايز يكلمني بعد المحاضره يقول لي مثلا نقربك باي حاجه مش هقول لا. طيب هو دلوقتي في رحله البريميوم IOLs دايما احنا بينا دلوقتي فيس فاكتس ان الكاتراكت سيرجي ما بقتش كاتراكت سيرجي، بقت ريفراكتيف سيرجي، ودايما العيان بيسال انا هلبس نظاره بعد العمليه ولا لا، وبيستعجل ان هو يلبس نظاره بعد العمليه. الموضوع ده ابتدى من زمان، فكان عندنا رحله طويله من البريسكوبيا كوريكتنج IOLs، ونقدر نقسم البريسكوبيا كوريكتنج IOLs كانت وقتها متقسمه لريفراكتيف او زونال ريفراكتيف IOLs ودايفراكتيف IOLs. الزونال ريفراكتيف اللي هي موجوده على الشمال هنا اهوت، مش عارف اذا كان في كرسي هنا اهوت، دي عباره عن زونز، والدايفراكتيف بتقسم اللايت ريز انسايد ذا اي عشان تدي فوكس لديستنس ويلي ان يو، كانت بنسميها مالتي فوكال IOLs. عشان نفهم المشاكل بتاعت المالتي فوكال IOLs لازم نقارنها بالمونوفوكال IOLs. المونوفوكال IOLs هي سنجل فوكس لينس، تاخد اللايت ريز من الانفينيتي توارد فوكس توارد سنجل فوكس على الفوفيا او على الماكيولا وتدينا الايمج على طول. في موضوع المالتي فوكال لينسز هي اللايت ريز بتتقسم جوه العين، بتتقسم عن طريق زونز في اللينسز او بتتقسم عن طريق دايفراكتيف اوبتكس الى 2 فوساي، 1 فور ديستنس and 1 فور نير. كده يبقى انا قسمت اللايت انرجي ل 50% و50%. ده اللي بيخلي الكونتراست انرجي او الكونتراستيفيتي في العيان بعد كده هو بتبقى قليله، فدايما بنبقى متوقعين مع المالتي فوكال لينسز العيان مش هيبقى شايف بنفس الكريسب بنفس الوضوح مع المالتي فوكال لينسز. ان انا قسمت اللايت انرجي زي ما يكون انا عندي وجبه واحده قسمتها على اثنين، بدل ما واحد بس بياكلها قسمتها على اثنين، ممكن الاثنين ما يبقوش شبعانين بس خلاص انا قسمتها على الاثنين وخلاص. فكده هو الكونتراستيفيتي لازم تكون موجوده، هتبقى لوست او ديكريس كونتراستيفيتي. مش هينفع ان احنا نضحك على الاوبتكس او نضحك على الفيزيكس، فلازم احنا كدكاتره نبقى فاهمين هذا الموضوع ونقول للمريض بقى ان لازم يتوقع ان هو يبقى فيه لوس اوف كونتراستيفيتي. الحاجه الثانيه، المشكله الثانيه ان هو الايمج بتاع النير ايمج اللي هو موجود اساسا في الفيتريس، هيبقى اللايت ريز مش هتقف، هي هتعمل ايمج وهتكمل بعد كده it will cause another blurred image على already focused image. يعني هنا يبقى عندنا focus image وفي another blurred image جاي من النير فوكس، وده اللي بيعمل الهيلوز. يبقى عندنا loss of contrastivity وعندي هيلوز، ودي هتبقى حاجه موجوده مع كل الترايفوكال لينسز او المالتي فوكال لينسز، سواء بقى دايفراكتيف اوبتكس او سواء ريفراكتيف اوبتكس. الزونال ريفراكتيف اوبتكس كان بتدي هيلوز اكتر بكتير قوي، لان هي العدسه متقسمه لزونز انترميديت ونير او انترميديت وديستنس ونير، فكانت الهيلوز كانت عنيفه جدا لدرجه ان هي اتسحبت من السوق. كان عندنا عدسه اسمها ريزوم دلوقتي ما بقتش موجوده. الدايفراكتيف اوبتكس كمان في مشكله ثانيه، ان انت لو احنا بصينا على الدايفراكشن ان هو بتقسم اللايت ريز المفروض نظريا 50% for distance 50% for near، لكن actually light rays مش under my complete control inside the eye. هتتقسم برضه ل another unuseful foci inside the eye. يعني في فوساي كمان بسبب الدايفراكتيف اوبتكس مش هتوصل للنير فوكس والديستنت فوكس اللي انا عايزها. ده بيبقى حوالي 20% من اللايت انرجي. يعني اكشولي لما بعمل دايفراكشن جوه العين بسبب دايفراكتيف لينس، اللايت انرجي ما بتبقاش 50% في كل فوكس، بتبقى اقل، بتبقى حوالي 40% كمان، وده بيدينا مشكله اللي هي الكونتراستيفيتي كمان بتكون اسوء. فاحنا عندنا هنا المالتي فوكال لينسز عندها مشكلتين، ودي بتشتغل بالسيمالتينيوس اوبتكس او سيمالتينيوس ترانسميشن في نفس الوقت، بيرسبشن يعني بشوف تو ايمجز في نفس الوقت، عندي لوس اوف كونتراستيفيتي وعندي نايت تايم هيلوز اند بلير. دي المشكله اللي موجوده حاليا معانا دلوقتي في الترايفوكال او المالتي فوكال لينسز. طيب ظهر بعد كده هو قالوا خلاص احنا هنحاول، المشكله كلها جت منين؟ جت ان انا عندي تو فوساي انسايد ذا اي. طب احنا ما فيش داعي نخلي الفوساي بعاد عن بعض، احنا هنخلي النير فوكس نزحزحها نخليها قريبه من الديستنت فوكس، ومش لازم
دكتور احمد بروفيسور اليو with us online, so if you in Arabic
yes
to
okay. So here they change to not only near focus, but they will divide the light rays into a series of foci to extend the depth of focus of the lens. So rather than distance and near focus. Now we have a series of foci along the distant focus in an attempt to reduce the nighttime halos and glare and improve the visual quality of those patients. And this is the basic concept of the extended depth of focus lenses. So as we know, that trifocal lenses provide a decent degree of spectacle independence, but the patient must accept some compromise in terms of visual quality and visual dysphotopsis in terms of nighttime halos, glare, and starburst. During the ECRS survey 2022, as you can see here, the extended depth of focus started 2016 by the Symphony lens of J&J and has some plateau, and now the extended depth of focus lens is taking up over. And you can see that the trifocal lenses was reached its peak 2019, and now there is slight decline and plateau until 2022. There is no accommodative IOLs so far, zero, and we started here with the enhanced monofocal lens. In 2023, now we can see they are almost the same. Now the extended depth of focus is taking up over, and the trifocal lens there is some decline of the trifocal lens usage among the ophthalmologists participated in the ECRS survey in 2023. And I expect, by personal expectations, that the 2024 you will see much EDOF lenses compared to the trifocal lens in terms of presbyopia correcting lenses. And again, in the same survey, when they asked the surgeon about the premium lenses or presbyopia correcting lenses they intended to implant in the next 5 years, 60% of the ophthalmologists participating in this survey mentioned that they will implant extended depth of focus lens, not the multifocal or trifocal lenses. So this is very much clear because of the visual dysphotopsis our patient complained, our experience with the trifocal lenses. So the extended depth of focus lens is not a new idea. It's an old idea, started 2016 by the Symphony lens of J&J. It actually based on the diaphragmatic optics, as I mentioned before, but rather than dividing the optics or dividing the light rays into two foci, just divide the light rays into a series of foci to extend the depth of focus lens. But still, it's based on the diaphragmatic optics, so there is a loss of contrastivity and still there is nighttime halos and glare. So the patient may have some improved visual quality, but still there is some visual dysphotopsis because we cannot cheat physics because of the diaphragmatic optics. The new concept nowadays is not to split the light rays. So we have now no light splitting concept, and the concept here is trying to redistribute the light rays inside the eye. We use 100% of the energy of the light rays to redistribute it to intermediate as well as distant foci. So we have many concepts. We have many optics trying to redistribute the light rays inside the eye without light splitting. Spherical aberration, as you know, extend the depth of focus. So we can employ the spherical aberration to extend the depth of focus of lenses. We have been decades trying to correct spherical aberration in terms of improving the visual quality with a monofocal lens, with a spheric monofocal lens. Now we are thinking the other way back. Okay, we can induce some spherical aberration without compromising the visual quality for the patient, at least subclinical compromise, but we can extend the depth of focus. Positive spherical aberration can extend the depth of focus in hyperopic shift, and myopic shift occurs with the negative spherical aberration. So the concept here, trying to induce some spherical aberrations to improve the visual quality, to improve the depth of focus of this patient. Here it comes that we can use both positive spherical aberration, little amount of positive spherical aberration and little amount of negative spherical aberration, and combine it in one lens and trying to extend the depth of focus of this lens without compromising the visual quality. And this is the basic concept of the EDOF minimal lens of CP in Italy. So this one approach to extend the depth of focus without light splitting. There is no diaphragmatic optics here, just we are trying to extend the depth of focus without compromising the visual quality by incorporating some spherical aberration. The same concept here with the isopure lens. Here we can incorporate negative spherical aberrations on the anterior and posterior surface of the lens, and here we use 100% of the light energy trying to extend the depth of focus. There is another concept which is called the X-wave technology, or wavefront shifting and extension by alconvivity, and by the idea it's based on wavefront, and as we know the wavefront is the imaginary line that connecting all photons of the light energy that moves in one phase, in a certain phase. And the light rays is the imaginary line perpendicular to this imaginary line of the wavefront. So here, with the wavefront, as you know, if the source of light is coming from far away, the wavefront will be something like this, and the light rays will be perpendicular, so it's parallel like this. So with the lens, we can convert these light rays, and we can stretch the wavefront by adding some central element in the central part of the lens, and change the curvature of this central element, trying to extend the depth of focus without compromising the visual quality for distance. And this is the basic principle of BBT lens, as we know. Details is beyond the scope of these presentations. So here we still use 100% of the light energy without compromising the visual quality of this patient, and without splitting the light rays. Another concept is the adding some small spherical, aspheric element in the central part of the optic of the lens, trying to extend the depth of focus, which is the basic principle of the Lucidus lens. We can change the power along the optic of the lens, subtle change of the power along the optic of the lens, which is the basic principle of the pure C lens, and it's almost the same identity as the Eye-Hans lens, but it has more power changes along the optic to extend the depth of focus. And actually this lens, as you can see here, the comparison between the monofocal and the extended depth of focus and the diffractive, you can see that the halos is much more evident with the diffractive optics compared to the refractive and compared to the monofocal lens. And you can see here, this is one of the patients that implanted with the isopure lens. You can see the amount of halos is not perceptible by the patients, and it's not bothering anyhow. But of course, it's less compared to the monofocal lens, the quality of vision. Another optic here, another optical principle is the going back to the future by, you know that this is the resume lens, the refractive zonal lens. Now we have another similar lens, it's called the iClip from Biotech. Again, we have multiple zones for intermediate and distant zones, but without abrupt changes between the different zones of the lens to improve the intermediate distance of this patient. As you can see, this is the wavefront now of this patient. You can see after implantation, you can see that the central part here is the beginning for intermediate, and this is for distance, and this is the third zone, interrelating zones between distance and intermediate zones. It's quite complex design, but actually improve the intermediate vision without compromising the visual quality for distance. The true extended depth of focus lens now has become in reality, which is based on the pinhole effect. We know that with the pinhole effect, we can extend the depth of focus, and we improve the visual quality of those patients, especially if the patient has some higher order abrasions because of the corneal tissues, the corneal scars, or some keratoconus, for example. So we have the IC8 now, which belongs to the Bosch-Lomb lens, and I think this will be lens available soon in Egypt. And I have some experience with extra focus lens of motion. You can see this patient has been implanted with this lens. This actually lens should be implanted on top of another pseudophokic lens, another lens. So it's an add-on lens with zero power, just to utilize the pinhole effect to improve the depth of focus and improve the visual quality in some patients. And this is the patient who had keratoconus, and the patient after chronic cross-linking, after doing PRK, customized PRK to improve the visual quality of this patient. The patient is asking for spectacle independence. I said, I cannot do this. But because of the patient was insisting, so I told him, okay, we can implant the extra focus lens and see how it's going on. And the patient was pretty happy. He can see 0.9 without correction and Jaeger 2 without correction with the pinhole effect. Of course, this lens has some side effects because of the nighttime visual quality is not that good because of the dimness. The patient usually experiences some dimness of the light because of this extra focus lens. So this is the most common EDOF lens available in the market in the meantime. So we have a lot of technologies, a lot of basic optical principles of some extended depth of focus lens that utilize the same concept. No light splitting, just trying to redistribute the light rays inside the eye without the splitting of the light rays. So to avoid confusion, the American National Standards criteria for EDOF lenses has set the criteria or the definition of EDOF lens. So we have to be careful that not every lens that can extend the depth of focus can be considered as extended depth of focus lens. So to mention that this lens is an extended depth of focus lens should provide a superior intermediate vision compared to the monofocal lens at 66 centimeter. At least should be in the visual acuity scale of 0.2 leg bar, and its extended depth of focus should be at least 0.5 diopters more than the monofocal lens, and without compromise, without too much compromise with the distant visual acuity, should be very much comparable to the monofocal lens, so not less than 0.1 of the log bar in terms of monofocal lens. So this is an example here. You can see this is the eye-hands lens. This is the eye-hands lens, and you can see that the focus curve, look at the 0.2 here, or 0.1 log bar visual acuity. You can see that this is the monofocal, the gray one, and this is the focus curve of the eye-hands lens. This is less than 0.5 diopters difference in the depth of focus. So this is not considered as a monofocal, as an extended depth of focus lens. This is the same company, the pure C lens, as you can see here, 0.1. You can see here, this is, it provides more than 0.5 diopters compared to the monofocal lens. So we can label this lens as extended depth of focus lens. So we have to be careful that not every lens can extend depth of focus is considered as an EDOF lens. So back to the title of the slide. Did EDOF lens fill the gap? We have multiple gaps trying to correct presbyopia for our patients. We have occupational issues, we have personality issues, angle kappa, dry eye, glaucoma, near vision. How this lens can fit or can act in this specific situations. For example, we can implant the extended depth of focus lens in some pilots. We cannot do this with the trifocal lens because we expect compromised visual quality with the trifocal lens or the diffractive optics trifocal lens, and the pilot or the patient might lose his or her license. So extended depth of focus lens doing very good, and I have personal experience with some of the patients that already implanted with the extended depth of focus lens and they are still flying. They kept their license because they need distance, very good quality for distance, and need intermediate visual acuity, very good intermediate visual acuity to read the charts and read the dials on the cockpit file. And this is one example of the patients. Here to skip this one, the patient is doing pretty good. He has excellent visual acuity for distance and quality for distance, as well as decent functional acuity for near, or intermediate, sorry. What about the angle kappa? Angle kappa, we theoretically prefer not to implant trifocal lens in patients with large angle kappa because this light rays, because of the function decentration of the lens, because of the large angle kappa, the light rays might hit one of the diffractive rings inside the patient's eyes, and this will cause a coma and nighttime hallus angulaire. And this is the theory behind this. You can see this is the light rays might hit the first diffractive ring of the trifocal lens, and this might compromise the visual quality. Although there is some controversies regarding the large and small angle kappa in terms of trifocal lenses, but with the EDOF lens, we published our series here, we proved that we can implant EDOF lens regardless of the angle kappa and angle alpha, and we still get very good results. So we don't look at the angle kappa and angle alpha anymore. And we theorize this because there is no rings in the EDOF lenses, there is no zones, even if there is some zones, the change in the power of the lens is very subtle, and the lens is pretty much close to the nodal point because we don't measure angles, actually we measure the chord length. So here, with the seeing, because of the lens is pretty much close to the nodal point, so the angle kappa, whether it's large or small, will not affect the visual quality of this patient. And we again presented our study regards the PVT lens of alcohol in terms of functional decentration, and we proved that we can implant the PVT lens in patients with large angle kappa. As you can see, this is the trifocal lens, and this is the PVT lens. You can see here, there is a small central limb, very subtle, can be seen on the slit lamp, compared to the trifocal lens here, because even if there is large decentration because of the large angle kappa, the patient will not experience a compromised visual acuity because the central element diameter is 2.2 millimeters. It's large enough so can accommodate large angle kappa after implantation inside the patient eye. What about the personality of the patient? We know that most of the persons on planet have 5 big personality traits. This is an example of one patient that has a personality type A, and every time steps inside my office has 2 papers like this effort asking for some questions about the lens and what about the cataract and etc. So this type of patient, I do not implant trifocal lens in this type of patients, but I can go for EDOF lenses. As you can see, the EDOF lens, this is a pure C, you can see the quality of vision is very much acceptable for this type of patients. And again, this is an example again for the Vivity lens. By lab study shows that the Vivity lens and EDOF lens, like other EDOF lens, produce a quality of vision similar to the monofocal lens and quite better, superior to the other diffractive lenses. And this is another example for the patient who usually comes in my clinic, he's asking about asphericity, he's asking about the mechanism of the lens, he's asking about everything. And finally, because I chose the right lens for the patient was pretty much happy by the last visit by implanting the EDOF lens for this patient. So we can implant EDOF lenses in those patients with personality type A. So don't worry about this. What about monovision? Because near vision is compromised with those kind of lenses. These lenses are designed for distance and intermediate vision. So we can employ the mini monovision or micro monovision in these patients. So we can target minus 0.5 in one eye and the other eye just for emmetropia. And we are happy to do this because the focus curve for the extended depth of focus lens on the right side here, the focus curve, you can see it's broad. It's not like the monofocal lens. So if we earn about 0.5 diopters in either side, the patient still can see a decent visual acuity at distance of 0.1 log mark or even better. And this is an example for one patient that implanted with the EDOF lenses, and the lens in one eye was just targeting emmetropia, and the other side is just 0.05. This after the surgery, you can see that the quality of vision is pretty much high, and the patient was pretty happy with the visual outcomes. He could read without glasses at 40 or 45 centimeters. He was pretty happy, and the patient was 45 years old. So we just employed the monovision in this case, and the patient was pretty happy again with the EDOF lenses. And to solve this issue, CIFI as well has another version of EDOF lenses called EDOF lens Proxa. 1 minute, please. One more minute. Okay. Proxa just to improve the visual acuity for reading. And you can see the patient has been implanted one eye with the mini lens and the other eye with the Proxa lens. That the patient noticed that one eye can read quite well compared to the other eye, but both eyes works in synergy together, and the patient is pretty happy, satisfied with the visual outcomes. You can see this is the defocus curve. We can extend the defocus curve by employing the mini monovision or the one eye with the extended depth of focus and the other eye extended depth of focus for reading. Here the defocus curve for both eyes is 3 diopters, other patients 4 diopters, and we can extend it even more, 4.4 diopters, without compromising the visual quality for those patients. Dry eye, again, is more forgiving with the EDOF lens compared to the trifocal lenses. And again, I have pretty much experience implanting the EDOF lenses in patients with dry eye, and the patient is performing quite well. As you can see, the visual quality of those patients after implantation is pretty much happy and superior compared to the trifocal lens. So I won't dare to implant the trifocal lens in patients with the dry eye. Glaucoma, again, we know that glaucoma reduces the contrastivity, and if we implant the trifocal lens, it will further compromise the contrastivity inside the patient's eye. So I would prefer implanting the EDOF lenses in those glaucoma patients. So it's not contraindication, it's maybe a relative contraindication to implant EDOF lens in glaucoma patients, but definitely a contraindication for patients with the trifocal lenses. So does EDOF lens, or did EDOF lens fill the gap? No. It's just filling, because there is very vibrant technology and improving, and every day we hear about new lenses that employ the extended depth of focus and trying to manipulate the light rays inside the eye. So I think the EDOF lens is a good compromise between the monofocal lens and the trifocal lens. There is less strict selection criteria compared to the trifocal lens, and I think for any one of you that is trying to enter the field of presbyopia correcting lens, start with the EDOF lenses, not with the trifocal lenses. Thank you very much for your attention.